多分向こうが発信側が今マイクを電話してるだけだと思うんで、ちょっとも触れてないので、そうだからこれは
Good morning, everybody. My name is David Barrett. I'm with the communications team here at WHO Europe. We're going to be starting our press briefing in the next couple of minutes, but I'm just addressing all of the journalists who are joining us online via Zoom with just a couple of reminders and a couple of requests. The first is, if you would be so kind as to ensure that your microphones are muted so that we don't have the extra buzz coming over the lines. That would be absolutely appreciated. Second, if you would like to ask a question to one of our 3 panel members today, please use the raise hand function of Zoom. Once you raise your hand, we'll be able to see that you are listed there, and we will do our utmost to get to as many questions as possible. However, one other request for that is if we are to take your question, it is important that you list as the name on the Zoom handle, that it has both your name as well as the name of your media outlet. Unfortunately, if we do not see your media outlet name, we will not be able to take a question from you. We will be starting in just a couple of minutes. Thank you so much for your interest, and we'll get started at 11 o'clock. Thank you.
Hello, everyone. My name is Luba Negro. I'm a communication officer at WHO Europe, and I will help moderate today's sessions. Thank you very much for joining us today, Thursday, November 19, for our press briefing on COVID-19 situation update in the WHO European region. Actually, it's been a while since our last press briefing, and many of you mentioned this in your messages. Obviously, this is not occasioned by the absence of issue or concerns. The reasons is that our panelists were on a few country visits and missions, and we couldn't work it into the extremely busy schedule. But please bear with us, keep following us, and we are very committed to stay in touch with you as often as we can. Now, without any further delays, let me introduce our panel today. And we have, as always, Dr. Hans Kluge, WHO Regional Director for Europe, Dr. Catherine Smallwood, Senior Emergency Officer in our office. And we also have today Dr. Siddhartha Datta, Regional Advisor on Vaccine Preventable Diseases and Immunization at WHO Europe. Dr. Datta will join us online because of the limited spaces in the panel. We hope we manage that. Dr. Kluge has an opening statement for you, and then we'll take your questions. Dr. Kluge, your floor is yours.
Good morning, everyone. There have now been over 15.7 million COVID-19 cases and nearly 355,000 deaths reported to WHO, with over 4 million more cases in November alone in the WHO European region. Europe accounts for 28% of global cases and 26% of deaths cumulatively. In the region, over 80% of countries are reporting elevated 14-day incidents greater than 100 per 100,000 population, with nearly a third reporting very high 14 days incident rates, more than 700 per 100,000 population. As a result, we are seeing increasing signals related to overwhelmed health systems, with reports that in France, for example, intensive care wards have been at over 95% capacity for 10 days, and in Switzerland, intensive care units are at full capacity. Outbreaks in schools, long-term care settings, and gatherings are also reported. In the past 2 weeks, COVID-19 deaths have increased by 18%. Last week, Europe registered over 29,000 new COVID-19 deaths. That is one person dying every 17 seconds in the European region from COVID-19. I would like to emphasize that every time we choose to follow guidance, stop the spread of misinformation, address denial, we contribute to preventing lives lost due to COVID-19. Right now, an average of 4,500 lives are lost to COVID-19 in Europe every day, and this is avoidable. If we all act, and those most privileged among us make an extra effort, we can make an impact. Thanks to your adhering to risk-reducing behavior, new weekly cases of COVID-19 decreased from over 2 million the week before last to approximately 1.8 million cases last week. It's a small signal, but it's a signal nevertheless. Those of you with the strength and ability to do so, I urge you to continue and step up to the challenge our society and way of life is faced with. Your country, community, family, and friends need you like they have never needed you before. The health and social workers whom you rely upon to help protect our senior members of society are under immense pressure. They and their families are making huge sacrifices. They need you like never before to act responsibly and to support them through the tough season ahead. In you all, I firmly believe that there is more hope ahead of us than despair behind us. 3 points today. First, if we all do our share, lockdowns are avoidable. I stand by my position that lockdowns are last resort measure. Mask use is by no means a panacea and needs to be done in combination with other measures. However, if mask use reached 95%, lockdowns would not be needed. But at the current 60% or lower mask use, it is hard to avoid lockdowns. We acknowledge that hundreds of millions of people are in some kind of lockdown today, but we learned that there is significant collateral damage associated with lockdowns, including increased mental health issues, alcohol and substance abuse, gender-based violence, essential health service disruption, and a need for improved economic support for the people affected, including those people who lose their jobs. We are aware of the technical and the political difficulties to resort to such measures. Too often, we have seen the negative impact of easing too quickly, following an understandable will from policymakers to free the public from periods of stringency. Too often as well, we have also seen how much these short political gains are quickly offset by the devastating impact of having to reinstall mandates shortly after they are eased. I am encouraging a tier system based on levels of seriousness in community transmission, with a set of proportionate measures that could be considered under each one of them. This can better situate government's actions along a gradient of severity that can go both ways without ever stalling. Secondly, technologies and pharmaceutical developments are offering us a new horizon. While vaccines won't stop COVID-19 entirely and don't answer all our questions, they do represent a great hope in the war against this virus. In the last few days, we have received good news with two particularly promising vaccines. However, this promise will never be realized unless we assure all countries have access to the vaccine market, that it is delivered equitably, that it is effectively deployed, and countries address pockets of vaccine hesitancy. It is also essential that we draw on the technologies already at our disposal, protecting our elderly and vulnerable with seasonal influenza and pneumococcal vaccines, for example. Furthermore, a reconfiguration of testing policies for contact tracing, isolation of cases and suspected cases, identification of superspreader events, and monitoring of high-risk situations through targeted testing and surveillance offers great returns on mitigating transmission. Here, our testing strategies need to be recalibrated to manage the largest bulk of transmission, to track cases, quarantine contacts, and isolate asymptomatic or mild cases. The recent scientific developments in rapid diagnostic tests, the antigen tests, provide a valuable option to shift the locus of the pandemic battle from the hospital to the households, the points of care, the community, to put the people in the center. I would also note that governments are to reflect on whether increased support is required for isolated and quarantined asymptomatic or mild cases. Thirdly, looking ahead, we must ensure safe learning for our children and make sure they enjoy the festive season. We possess now a wealth of country practices on how to go after the virus without going after the people. We have been able to ensure safe learning for our children by keeping the vast majority of schools open for almost 100 consecutive days. Tomorrow is World Children's Day, a day that reminds us to preserve the rights of children amid this crisis. WHO remains firmly committed to support the countries of Europe to keep primary schools open and ensure safe learning for all. Children and adolescents are not considered the primary drivers of transmission, and as such, school closures are not considered to be an effective measure for the control of COVID-19. To those countries considering this course of action, I would request that you consider the adverse effects in terms of educational outcomes, mental and social well-being of school closures. Where closures are enacted, we ask that children in vulnerable situations and with special needs should be prioritized to receive support and to attend in-person teaching. And to children particularly, a short note on Christmas and the festive season ahead. It will be a different Christmas, but that does not mean it cannot be a merry one. During the Ramadan, community-based groups found safe solutions of breaking the fast, including virtually or delivering meals to homes for distance celebrations. A virtual Diwali with free line on events run by municipalities across Europe assured safe revelries. Cherish the festive season with those close to you. If it's a large gathering with vulnerable people, you may then postpone that gathering until you can safely gather. Despite the cold, if local restrictions permit, gather outside with loved ones for picnics in the park. We see signs of community spirit and support already across the whole European region, with homeless shelters planning to deliver warm meals and food packages to the homeless at Christmas, online festivities planned, and popular department store Christmas windows being unveiled through Facebook live events and so on. In summary, my 3 points today. 1, if we all do our share, lockdowns are avoidable. 2, technology and pharmaceuticals offer us a new horizon, hope. And 3rd, we must ensure safe learning for our children and make sure they enjoy the festive season. Ultimately, these pandemic times are affecting all our lives, but we cannot give up when we have so much to gain. I urge you to hold on to hope and make every effort in your communities to reduce your personal risk and the risk to the people and the communities around you for the health and well-being of all. Thank you.
Question per person, and if there is time, we'll have a second round. I will start as usually with the questions provided in advance, and thanks again to the journalists who took their time to do so, to keep in touch with us in advance. Please remember to unmute your microphone when you raise your questions. The first question that I want to raise here is from Hiroman Bakoeva. She's contacting us from Radio Ozodi, the Tajik service of Radio Liberty in Prague. Hiramon, thank you so much for your question. I'll read it as it has been provided. Over the past several weeks, there have been encouraging reports of positive test results for the US-made COVID vaccines, Pfizer, Moderna in brackets. If they are approved for use, is there a chance that these vaccines will be available to residents of countries such as Tajikistan and other Central Asian republics? Dear panelists, I have to tell you that we've got quite a lot of vaccination questions. This is a hot issue now in the region. So I suggest we just start with the first batch of questions on vaccines. Luckily, we have Dr. Datta with us. Dr. Kluge, can you help answering this question?
Yes, thank you, Hiramon, for the question. WHO's principle has been since the very beginning that any COVID-19 vaccine should be a global public good. So the solidarity and equity in access to the vaccine is key, but it's not only the access to the vaccine, it's also the vaccination itself, meaning the deployment. And that's where the WHO Regional Office for Europe is working on. Number one, that countries have equal access to the vaccine, but also from A to Z, because we're still not sure, for example, on which kind of circumstances that the vaccine has to be stored in. Globally, you may have heard of the COVAX facility, which is unique in its history, which has 186 countries participating. It has the largest pool of potential vaccines, and WHO developed an allocation framework because we know that whatever vaccine there will be, the supply in the beginning will be shorter, less than the actual demand. And the priority should go to the 3% of the population, which are health and social care workers, then to the elderly people, and then to the people, we call it with comorbidities, who have several diseases at the same time, which lowers their immunity. For Central Asia in particularly, they are part of the COVAX facility, and I myself had productive discussions with the new chair of the Gavi board, the Global Alliance on Vaccine, President José Manuel Barroso, but also with the High Commissioner of the European Union, Mr. José Borrell, to see that there is really a solidarity also between the EU and the non-EU parts of this region. And then, of course, we have a number of countries outside of the European Union in the region also in the process of developing a vaccine. Thank you.
Sorry, thank you so much, Dr. Kluge. Then we have a question from Linda Kennedy. She's working for the International Broadcast Agency Future Story News for CGTN. Linda is asking the following. The Russian-developed vaccine Sputnik is being sent to other countries, including Hungary. What does WHO know about Sputnik's clinical trials of safety? And what would you say to people if they are invited to have the Sputnik vaccination? I'm just looking, Dr. Kluge, would you be ready to answer this question as well? Yeah, I'm sorry for insisting.
Thank you, Linda. In fact, a couple of weeks ago, I was also myself in the Russian Federation, where I met healthcare workers and the Prime Minister, Minister of Health, Dr. Murashko, and we obviously was a main discussion point. So the World Health Organization is in touch with the Russian vaccine developers on exchanging data on what we call phase 3 of the clinical trial. There are 3 phases. Phase 3 is the phase that thousands and thousands of volunteers are getting the vaccine, particularly to study the safety. So this is linked to the WHO guidance on target product profiles. It means the characteristics to which this process has to adhere. Ultimately, the country's vaccine and drug regulator then have to approve the authorization of a vaccine, or the country can also rely on other robust regulators as well. So this is in process for the time being, and of course it's always very difficult to put a very clear timeline. This is a process which is standardized for any vaccine under development, and of course there is no any vaccine which can bypass the essential safety and effectiveness criteria. As to volunteers, it is up to the population, of course, to step forward if people would like to volunteer to be included in the phase 3, and for this the people are to contact their local health authorities or the research institution.
Thank you. Well noted. Another question from Ioannis Goranitis from Inside Story Greece. Ioannis is following our press briefing regularly, so I would like to keep this question in full. It's quite long, so we have to break it down in a couple of segments, if you don't mind. So the question is the following. Apart from conspiracy theorists and deniers, there is already a significant percentage of Europeans that appears reluctant to vaccinate. The questions. What's your advice to governments and civil society in order to battle hesitancy and denial? Should they consider tightening their vaccination law or even make COVID-19 vaccination mandatory? Are you anyhow worried that politicians and media around the world rely too much on the vaccines and encourage the public to consider them as silver bullets? If you allow me, I would address the first two parts on government, on hesitancy and denial and mandatory vaccination to Dr. Datta, and I can see him online. Dr. Datta, can you hear us?
Yes, I can hear you, but do you hear me?
Yes, very well, go ahead.
Thank you so much. Thanks for that question. And on the vaccine hesitancy, the part that you have raised, and thank you so much for raising that question. We have seen a degree of vaccine hesitancy also during the routine immunization vaccination coverage in the WHO European region, despite we see a very high coverage, which indicates that there are reasons for remaining pockets of under-vaccinated individual, which are actually, the studies have shown in our region, they are very context-specific. Along the same line, we see the behavioral insight surveys that have been done by WHO European Regional Office in several of the European countries in recent months indicate that many people are indicating they're unsure about the vaccination against COVID-19. We just wanted to also highlight here that this can be actually expected in the current circumstance, more so when there are still so many things unknown about these vaccines and when this will be eventually licensed, when they will be available, and also what are the possible side effects maybe. In the absence of these information, a sort of a speculation has got an ample opportunity to spread. But just wanted to also reiterate that these findings at this point of time are extremely valuable for any stakeholders to make use of information and also see what needs to be communicated. But this does not mean at this point of time that everybody is uncertain and they will decline when the vaccine becomes available. What does that mean is that all stakeholders, the national authorities, WHO, along with partners, as you heard Dr. Kluge mentioning what the process being done to prepare the countries, we all have a responsibility to communicate clearly about the vaccines when they become available to ensure that any questions or concerns from the community are addressed in a transparent and clear manner. The other part which was raised about the vaccine mandatoriness, just wanted to make sure that we see and understand the immunization system, which is within the part of the bigger health system in the WHO European region, are very varied. And I think it's not one size fits all will ensure a policy in place. The policies which will be put in together by the countries will have to be tailored to their own setting. What works in a country or may not work in another country. The features of the context specificness of their policies have to be looked in. What are the different features for the community's acceptance, and also the context around the community's perception need to be looked into to ensure whether the policy or vaccination laws that are being put in are relevant to their setting. In the routine immunization coverage in the WHO European region, we are very much aware that some countries do have a mandatory policies in place while the other countries don't. But we have seen equally high coverage in several countries of our region. What is of paramount at this point of time is a community engagement, understanding their knowledge, their concerns, and their questions, and making sure that the system is in place to address that in a transparent and a clear manner. Thank you so much. Over to you, Luba.
Thank you, Dr. Datta. And I think the question, the segment about politicians will go back to you, Dr. Kluge. So any worries that politician media can consider COVID vaccination as a silver bullet? I think you mentioned several times before, but please restate your message.
Right. The vaccine is very, very important, but it's not the silver bullet as yet, because we know that the supply will be shorter than the demand, particularly in the beginning. The positive news is that this is an unprecedented speed with which vaccines are being developed and also treatment options. But good science takes time. So in that sense, let's hope that in the next 6 to 9 months will be a lot of progress. But the main point here is that we should implement what we know is working. And the good news is that there are a number of low technology, cheap public health measures that we know are working, like hand washing, cough hygiene, physical distancing, general systematized mask wearing in public places where physical distancing or a proper ventilation cannot be avoided, and control on larger social gatherings. Thank you.
Thank you, Dr. Kluge. I think we're done with the vaccination questions received so far. So we're going to the question from Oskar Gorzinski from the Polish Press Agency. And Oskar is asking, there was a new preprint study coming out of Loyola Institute of Immunology suggesting that for most people, immunity to the coronavirus could be long-lasting, more than just a few months, based on the slow decay of cells necessary to prevent reinfection. Is this considered with what we've learned about the topic so far? What are the implications of it? And I'm turning to Dr. Smallwood for some information on that.
Thank you, Luba, and thank you very much for the question. Indeed, we're still learning about the immune response to COVID-19. And this piece of research, although it's in preprint, so it still requires further peer review, is very encouraging, and it looks at a comprehensive aspect of the immune response to COVID-19 across a significant period of time in a quite a large number of patients. So the results are encouraging, and as the regional director said, this is just another reason for us to hope that our immune response will be able to respond to these types of viruses. However, we do know that some reinfections have occurred over the past 9 months. Those have been documented in the scientific literature. So we still need to be very careful not to make any assumptions about our own personal immunity if we've had COVID-19, and we still need to follow all of the recommendations that are in place.
All clear. I think we're almost done with the questions received in advance, so I'm going to the colleagues who raised their hands online, and we have Gunilla von Hall from Svenska Dagbladet. Gunilla, if you can hear us, please unmute your mic and raise your question.
Yes, can you hear me?
Yes, very well. Go ahead.
Thank you for taking my question. As you said, there are very promising vaccine news the last few days, but how concerning do you think it is that it's still unknown how long the immunity will last? Because if we have vaccines that last 2 months, perhaps it's not so useful. So how long immunity is needed for the vaccines to be really efficient to stop the pandemic in Europe? Thank you.
I think it's a little bit of a continuation of the previous question, Dr. Smallwood. Do you have anything to add?
Thanks, Gunilla. I don't have much to add. I'm sure my colleague Siddhartha will say something specific about the vaccines. But indeed, that's a question that of course, is on our minds. How long will the immunity conferred by a vaccine, if it's safe and effective, how long will that last? And that will obviously have big implications once we know that, and once the findings from the trials become apparent. Big implications for how we plan continued deployment, increased production, and all of these types of things. But I'm sure Siddhartha will be able to say more.
Dr. Datta, do you have anything to add? Please feel free. You have to unmute your phone.
Do you hear me now?
Very well, go ahead.
Yeah, thank you so much. Thanks, Katie, and thanks, Katie, for that. Thanks, Gunilla, for that question. It says, I think we need to understand that these results from the vaccine trials, phase 1, phase 2, phase 3, as you heard from the RD, these need to be relooked into very closely to understand two different parameters, the safety and efficacy of the vaccine. However, for the longer term immunity, this has to be then followed up further when the vaccine is being used for a period of time, number one, and to the wider population groups. So there are several vaccines, candidate vaccines, there are around 10 of them, which have moved into the phase 3 trials of the production. And WHO is working very closely with the vaccine developers to understand and get the details of these clinical trials. These information will play a very pivotal role as we look into understanding the longer term immunity for each of these vaccines. Just wanted to also add on here that the vaccines which are being used, this unprecedented effort being made to develop the candidate vaccines, we are using both traditional technologies as well as the newer technology. This unprecedented effort to use newer technologies gives an additional time for the developers to share this information about the immunity in general. So I think we will have to keep waiting, and as WHO has been mentioning, that any evidence being shared by the vaccine developers will be of critical importance for the global immunization community to learn about the characteristics of this vaccine. That data transparency is within the part of WHO's landscape document, where the results of these vaccines, both for safety, efficacy, and in further, the longer-term immunity perspective will be made available. And we really like to thank all the developers, vaccine developers, to share this information, which is of very critical nature. Thank you.
Thank you all. We're moving on. I can see Linda Kennedy is raising a hand. Linda, can we keep your second question for the next round of questioning? And I'm moving to Tom Magner from Carriers World Life. Tom,
thank you very much.
Please unmute
indeed.
yourself.
Thank you very much. Can you hear me okay?
Very well, but if you can raise a little bit the sound.
I will project a little. I'm on maximum volume. Is that a lot easier?
Yes, absolutely. Go ahead.
Okay, brilliant. The UK government has spoken a lot about mass testing people in advance of a vaccine, presumably as a way to reduce or lift restrictions. So how should a mass testing system, presumably based on quick turnaround antigen testing, work in practice? And most importantly, while earlier you mentioned priority for children, how should nations make sure that they give top priority to unpaid carers and vulnerable adults in any mass testing?
Thank you very much, Tom. Mass testing, and I'm looking at Dr. Smallwood. Dr. Smallwood, will you take this question?
I can take the question. Thank you. And thanks, Tom. Indeed, a lot of mass testing is happening in different countries, sometimes nationwide, as we've seen in Slovakia, using antigen detecting rapid diagnostic tests, but also in other countries at a more localized level, as we've seen in the UK recently, in Liverpool, and also in Denmark here. I would caution around saying anything generalizable about mass testing. They're undertaken for very different purposes. They use different types of tests, and they require different levels of capacity to do, and lead to very different types of interventions. So mass testing is something to be considered. And there are several countries and several settings where they are being considered. In doing so, they certainly need to take into account the capacity of the testing systems to increase testing, to conduct mass testing, either in a specific location or across the country. And countries should bear in mind, or health authorities should bear in mind, the basic principle and the recommendation of WHO that testing should first reach all suspect cases. We also need to bear in mind the purpose and the location of these testing. So as you correctly highlight, a number of strategies to conduct mass testing have been targeted at locations that are considered high risk, such as long-term care settings or other areas that are seeing outbreaks. And that would be something that is considered useful because it enables us to pick up many more cases than a more limited testing strategy would be able to do. And then thirdly, you'd need to look at the type of test being used and the reliability of those tests. So rapid diagnostic tests, for example, have both pros and cons in their use, and these need to be very carefully studied based on the purpose of the testing, the epidemiology in the environment, in order to ascertain whether they would be a useful tool or whether the more standard PCR tests would be more appropriate. So there's a lot of different variables to take into account. Certainly, high-risk groups are key in conducting wider testing strategies, and when there is scope to do that and spare capacity in the labs, that's really a useful way to get ahead of the virus. Thank you very much.
Tom, if I can add here, so there's also something in between, right? Between testing of the suspect cases and then the mass testing. We see that in several countries, the system is getting clogged by using only the PCR test, and that it's disconnected with the whole system of tracing and isolating. So it's, as Katie was telling, that the antigen test indeed is not that perfect, but there will be a need to move to a kind of a hybrid system of using the PCR and the antigen, also to put more, let's say, effort on the people, on the population themselves, which really have to be in the center of the fight against this pandemic. Thank you.
Thank you both. We have 25-30 minutes to go, plus minus, and 6 more questions online. So Esmir Milovic from N1 TV Bosnia. Esmir, can you hear us?
Yeah, I can hear you. Can you hear me?
Yes, absolutely. Thank you for joining. Please, go ahead.
Since we spoke last time, Dr. Kluge will remember that I asked about the situation in the Western Balkans. And now we are worried here because it's not only that we see the rise of numbers of new cases, but we also see the rise of deaths here in the region. Are you worried about the situation here in the region with what's going on, especially with the status of our health systems in the region? And also, have you already discussed the distribution of vaccines with the countries here in the region? Because we know that we will have, for sure, numerous problems with the distribution of vaccines. Thank you.
Esmir, thank you very much for raising these important questions. And by the way, the distributions of vaccine, it's a major issue raised by the media across the region, but particularly in the central and eastern part of our region. I'm looking at both panelists, it would be good to have comments from both of you, and I would like Dr. Kluge to start if possible.
Yes, thank you, Esmir. Good to have you back, indeed. Am I worried? Yes, I'm worried not only about the Balkan, but about all 53 member states and beyond. The European region in general is once again the epicenter of the pandemic, together with the United States. But as I will try to tell also in my message, I'm also hopeful. I do see, and we all should see, light at the end of the tunnel, but it will be 6 tough months. So that means we have to implement what we know is working on the vaccines. In fact, very recently, I had a video conference meeting with 2 commissioners of the EU, Commissioner Dr. Stella Kyriakidis for health, and then also Commissioner Oliver Varhely, responsible for neighborhood, which includes the West Balkans, and also with Professor Peter Piot, joined the advisor to the President of the Commission, exactly on looking at the equal access in the West Balkans. And I was very glad that through our joint efforts, the West Balkan is included in the joint procurement. I myself was last week in Albania, where I discussed similar discussions with Minister Ogerta Manisteriou. And then the distribution, yes, absolutely. So this is what I was mentioning, the A to Z, which has to be looked through. And again, this is not only typical for the Balkan, but obviously it's very important that the population in the Balkan adhere to the public health measures, which I was repeating, and also a strong leadership from the political leaders with a clear and consistent message, because what we have to avoid is what I see or saw in several countries, that scientists and the politicians are at different ways. So decisions have to be based on sound scientific experts, and I myself know from the experience that the West Balkan has great experts, really, great experts.
Yes, Dr. Smallwood.
Thank you, Regional Director. Indeed, as we said in the past, we would expect a rise in deaths following a rise in cases, as you rightly allude to, and we normally expect that to be between 2 or 3 weeks. What's important to understand here is that as cases increase and as they become more dispersed in our communities, they will increasingly affect those who are most vulnerable, and COVID-19 will have more severe outcomes in people who are more vulnerable, i.e. people who are older, people who have chronic diseases. And as that happens, the hospital beds will fill up, the capacity of the hospitals and the health system to deal with those cases will be met, and then outcomes will tend to get worse because the quality of care that can be given to overcrowded hospitals starts to decrease. And that's why we really need to focus on getting the case numbers down in the Western Balkans and across Europe to relieve the health system and reduce the number of deaths. And that's really the only way to go about it. And that requires strong public health strategies, strong individual measures, and public health and social measures to be complied with, and actions from all levels. So those are the points that I would really reinforce here. Thank you.
Thank you very much. And Jamie Keaton, the senior correspondent of the Associated Press in Geneva. Jamie, can you hear us?
Yes, I can. Thank you so much for taking my question. Dr. Kluge, nice to see you again. I have actually several questions, but I'll try to keep them. You mentioned the tier system. Could you just give a little bit of detail as to what that is? We've heard that idea come out before. What is your idea that makes that different, the gradient of severity, as you mentioned? And if I could, I wanted to talk about AMR also, but I guess I can do that another time. Just as a second thing, if I could just slide in about Finland and some other countries that are showing a less of a second wave. Could you explain why that is? Thanks.
Thank you, Jamie. Great to see you. So I will start and then pass also to Katie. The idea of a tiered system is that in March, the lockdown was a kind of a shutdown. We were all hit by surprise by the speed and the severity and devastation that we shut down the economy and the schools, and basically we did crunch the virus, but we also crunched, unfortunately, quite a bit the people. This is one background. The second background is what we need now is policy coherence and predictability. That the people do not think that we policymakers are flip-flopping. One time this, another time is this. So the tier system thus has very clearly spelled out, based on epidemiological indicators, the community is in this situation, and then those range of measures can be implemented. If it gets worse, those range of measures are then to be implemented and are more severe, so that the people have a kind of predictability and certainty that if the government implements more stricter measures, it's not because they have another idea or the situation drastically, someone decides something not evidence-based, it is really faced. So the predictability and the policy coherence are the background. On the AMR, thank you, Jamie, for your interest, really for working with us. I really appreciate this, and we took this, the interview we did also very seriously. And because you mentioned it, I would like to tell, like we have been communicating with Jamie of AP, that this is a concern, that we have a pandemic of COVID-19 that should not turn into a antimicrobial resistance pandemic, because we know from evidence that about 15% of the COVID-19 patients in fact need an antibiotic because of bacterial co-infection. But the studies that we did in 9 countries in the European region show that about up to 75% to 90% of the COVID-19 patients are taking antibiotics. So thank you for flagging this. And now I forgot the third point.
Thank you, Dr. Kluge. Yes. Dr. Smollett, something very briefly to add, or?
Yes, I will say a little more about the tiered system and maybe hand back over to Hans if he wants to say something about Finland, which I think was the third point. But exactly in the way that the regional director described, the tiered system allows predictability and coherence. And what it does, it allows both the transmission scenario to be looked at, but it also allows an assessment of how the health system or the public health response is working. And that's both in terms of the performance, i.e. how long does it take for people to get their tests results back? How well do people adhere to the public health and social measures that are being implemented? How well is the health system, the hospitals and the other health facilities involved in case management, how well are they doing with the current caseload that they're getting? These are things that will change in different countries and within different countries in different locations. And so the transmission scenario and then the coping capacity and the response is really the important thing to keep in mind. Now, we have guidance, and those were issued on the 4th of November, and would really encourage countries, and we are working now with countries to look at those and to use them. And the ultimate aim is to prevent countries from going into a worse situation where more strict measures would be implemented. So it's really relying on an increased knowledge that we have around what works and an increased ability within the public health agencies, both at national and international level, to calibrate those public health responses to the specific situations. In Finland, of course, Finland is seeing a pretty good situation at the moment compared to much of Europe, low incidence, and really we see that as a really strong community engagement at the Finnish level, combined with quite rapid decision-making taken at the country level, decisive measures being implemented, and strong adherence to those. But perhaps the regional director has something to add. Thanks.
Thank you for the detailed answer. We have Alice Tider from Euronews online. Alice, can you hear us?
Can you hear me?
Very well, go.
Thank you for taking my question. So it's actually two-pronged. So Dr. Kluge, you mentioned that lockdown should be a last resort measure. A number of European countries are back under national lockdown, so France, the UK, Austria. They already were in lockdown in the spring, and then when they lifted the measures, the virus ended up coming back stronger. So how can we prevent a repeat of that when they start easing again, which is expected at some point in December? And then the second part of my question, you already alluded to that a little bit, is about the multi-tiered system, which you came out in favor for. The UK already tried that and then ended up imposing a national lockdown. So what should they have done better?
Thank you very much, Alice. I think we'll just take the first part first. So on lockdowns, Dr. Kluge. Okay.
Yes, ahead. Thank you, Alice. Absolutely. I must say that as we have been stating consistently, when we anticipated a lifting of the first lockdown, we never anticipated that there would not be a flare-up or a second wave, because this was in the line of the expectations. Key issue is that it should be done just like when countries are moving to a lockdown. The same principles should hold when countries are lifting. It means gradually and safe. We had a meeting with the 15 Ministers of Health a couple of weeks ago, and when we discussed the schooling, In few countries, there was an outbreak of the schools, but the national authorities admitted that the measures were not implemented safe enough and gradual enough. So this is basically the key one, because you're right, if the second lockdown is lifted, the virus has not gone away. The virus is not worse, but not better, which is both good and bad news. So in that sense, the virus will be merciless again, unless everyone is doing its share, which is what Katie was mentioning, the community engagement. And that's so important that every one of us has to do its share for ourselves, but for the other ones. And that if young people, for example, feel less vulnerable, yes, maybe not to die less, but we also have the long COVID that we see examples of athletes and really people who are used to do sports and strong, weeks and months with abnormal periods of tiredness, mental health issues, anxiety, cannot sleep at night. So it's not a normal flu. So everyone has to do it. And then second, the local public health measures, right? So if there's a lockdown, the other message maybe to stress more is take advantage of that time to strengthen your test, trace, isolate, care system so that it's not just wasted, because with a lockdown you will see in strict lockdown 2-3 weeks, an example, but take advantage then to strengthen your basic public health system. Maybe on the second one I will give to you, Katie.
Thank you. I'd just like to reiterate the point the regional director made, is what comes after the lockdown is the biggest question at the moment. We're seeing that these partial lockdowns, or sometimes in 4 or 5 countries in the European region now, we're seeing what's called a full lockdown, although schools have on the large part remained open, which is a good thing. But what comes next is the main question. I'd also like to highlight that in these tiered systems, they may not be perfect first time round. We need to, give them the time to work. These systems that are put in place, they may take time. Even the very, very restrictive measures that are in place across several countries, including England at the moment, take time to see an impact in the new cases and new deaths, and indeed on the health system. So things will not happen immediately. And these tiered systems, they need to be adapted and improved. They're not going to be perfect first time round. The second point I'd like to highlight is a more positive one. Despite the alarming numbers, despite the real strains that are being placed on our health systems and on our testing systems, there are some positives, and I'd like to highlight that all-cause mortality across the 24 countries that report to Euromomo is significantly lower now than it was in the spring. And we've seen over 230,000 excess all-cause deaths due to all causes during this pandemic. But the proportion that are being seen now is far lower than those being seen. So we have made improvements. Our public health and social measures have got better. Our public health systems have got better, and our care for cases also has improved. So there's a lot of positives to be seen here. And I think we should really focus on keeping things improving, and then we will get there. Thanks.
Thank you very much for encouraging messages. Now we have a question which has been from Konstantinos Davanis, the EU correspondent in Strasbourg, Hellenic Republic Television in Greece. He's raising an issue, a question which has been quite popular recently. I'll read as provided. After the Netherlands, Denmark and other countries, thousands of mink sheep have been infected with coronavirus in Greece, without anyone knowing so far whether the owners on the farm contracted the coronavirus from humans or whether the animals returned a mutated coronavirus to the people who worked there. Scientists say that at least 170 variations of the virus have been identified in these animals. My question is, do you think that the coronavirus variations such as cluster 5 in the Danish mink or the Y435F mutation from the Netherlands may have been transferred to Greece from Northern Europe? Can a new local mutation develop? How dangerous for humans are mutations of the virus from minks? As researchers say, they can be transmitted through other animals near farms. Ultimately, culling the minks is the only solution. What is your opinion? The question is long, but the general issue is minks, variations, transmission. Please, Dr. Kluge.
Thank you, Lua. And then I will pass on to Katie for some follow-up. Because I have been involved quite a bit here indeed in Denmark, and we did a press conference together with the Ministry of Health. Couple of points here that indeed seem that the mink farms are a reservoir where the coronavirus is thriving, and we know from experience also with other viruses when there is a spillover, meaning transition between animals, in this case minks, and humans, that different genetic modifications are possible. This famous cluster 5 has been at that time been identified but has not appeared anymore since then in Denmark, and as of my knowledge was only in Denmark, but I will pass on to Katie then. So a key issue is to strengthen what we call the biosecurity around mink farms, and also to commend the Danish government that it's because they are systematically doing genomic sequencing of 14% of all COVID positive patients that this has been detected. So this is a positive, and since then the 14% is drastically being increased, and I would like to express appreciation to the Danish government for transparency, because this shows again, in fact your question highlights the importance that we really, in a very transparent way, whether in Europe, globally, have to share all the knowledge that we have, including on the genomics. And maybe a couple of other points, Katie, for you.
Thank you very much. And indeed, we're working with Greece. So we have been in touch with the Greek Ministry of Health on the situation in Greece. And in fact, immediately after this press conference, I'll be joining a meeting between WHO, Ministry of Health Greece, and ECDC to look at the situation there in more detail. Many questions you asked. So the regional director outlined our broader concerns around the public health risks that may come from that, and the need for really to place specific measures around mink farms to avoid the transmission between humans to animals and back. Local mutations in mink do happen, and these have been documented, and is why we have seen several different countries report different mutations and different variants circulating within the mink populations, and then sometimes into re-entering human populations, as was reported by Denmark. The key here is strong human-animal surveillance at the animal-human interface, and this is a really something that we would recommend any countries that have large mink farming industries to put quite a lot of attention to at the moment. In terms of culling, of course, where there are infected mink and where this has been documented, and we encourage countries to look at infections within their mink populations, culling is an appropriate measure, in addition to other measures that might be implemented in terms of preventing transmission, such as biosecurity, such as increased testing in communities, human communities that either work around the communities of mink farms or in the sector itself. And then there are other measures that would need to be taken if there is evidence, such as what was seen here in Denmark, of a greater proportion of mink-associated variants transmitting in the human population, including cluster 5. As the regional director said, this cluster 5 variant, those specific mutations that are associated with cluster 5, they have not been documented in other countries, and Denmark has not identified any further cases of this cluster 5 variant among humans to date. That means that the 12 cases that were detected in September still remain those only 12 cases reported to WHO at this stage, and this is also encouraging news. Thank you.
I think we still have 1 minute, if I can still keep your attention. Linda, are you still online? You haven't?
Yes, I am. Thank you. I'll make it quick. Going back to how we started the press conference on Europe, I'd like to ask, do you feel Europe is turning the tide on coronavirus cases, given the 10% drop over the last week due to lockdowns?
Thank you, Linda. Dr. Kluge, very quick answer if possible.
Right, Linda. So there was good news and not so good news. I mean, the drop in new cases is a great news and is a testimony of the people doing what has to be done and everyone do its share. But the mortality has increased with 18%, right? And then we really have to protect our vulnerable. So we have to calibrate this message. So I would say Europe is capable to turn the tide, absolutely. But we have seen that the virus does not need a lot. The virus thrives on the vulnerable, on doubt, on governmental decisions being laid, and where there is a schism between politics and science. So in that sense, it is possible. This is hopeful. We know that the vaccine will be too late for this winter. So we have really to stick together and implement the low-tech measures which we know are working. So I am hopeful, yes, but I'm also very, very vigilant because we have seen that health systems can be very quickly overwhelmed. And maybe my final note is my admiration to the health workforce, the social workforce, because those people had no break, their families had no break. I see it when I go on country visits, I speak to them. And really, the people of Europe have to continuously to applaud them. Thank you.
Thank you both panelists and all you guys online for joining us today. We have to conclude now. There is no more time, but just to tell you that the video of this presser will be published on our YouTube channel in a couple of hours. If you need it faster, get in touch with us. So have a good day, stay healthy. See you next time. Bye-bye.